let me tell you a little bit about Lawson Health Research Institute and iThink Research. We do have a URL. It's just www.ithinkresearch.com. And it's a lab that I started about 5 years ago when I became very interested in the area of knowledge translation and health informatics. And thinking about the fact that, so my primary appointment was in medicine, and realized that on the medical side, we didn't really understand how to solve all the problems, even though we thought we did. And yet there were people around the campus in health sciences, in information media services, and computer science who were doing excellent work, but they didn't actually talk to the people on the clinical side. And we started this lab with the idea that we should create a collaboration. And that's really how all of the work that I've been doing in eHealth, if you want to call it that, started. Lawson Health Research Institute, just so you know, is like the University Health Network. It is the research arm of the two hospitals, 1,200 scientists, $71 million in funding, and we all have affiliations with different faculties around the University of Western Ontario. So just because you're from Toronto and not everybody's left Toronto, I'm joking. It is a standing joke, however, in London that everything is Toronto. So what do I want to talk about? I really want to talk about you know, the application of evidence-based. So why did Kevin introduce the fact that I'm doing work in adherence or compliance research? Many years ago, actually I did my PhD at McMaster with Gordon Guyatt, who some of you may know. And when I went to Gordon and said, I want to study medication adherence, he said, well, that's insane, Femida. You know, what's the relevance of that? Because, you know, there's no evidence, et cetera. And I said, that's the bottom line, Gordon. We spend so much money doing clinical trials, and we spend so much time doing systematic reviews to come up with the evidence, but at the end of the day, if people don't use the medication that they're supposed to be using from all those wonderful trials, who cares? So let's look at new methodologies to begin to understand adherence. And on the basis of that, I actually started to develop a series of white papers or evidence-based approach on how to conduct medication adherence research. How do you deal with retrospective data? How do you deal with prospective data? I'm framing that for you because as we then embarked upon this journey around health informatics and eHealth, we started to look at the same approach. Look, we have evidence. How do we begin to understand that evidence? How do we do good research where we actually understand what we're doing in a way that's reproducible? Okay, so I'm just going to follow this outline, and it's actually, I've referenced a paper. So for this particular presentation, what I did was I utilized a paper that we've published. It was at an invited talk in the UK, and it was around evidence-based knowledge in eHealth systems. And I'm not sure if it's available, but if you email me, I'm sure I could individually send you a PDF version of the paper. So who cares about all of this? One of the realities when you see patients, and even if you don't see patients, if you think about your family members and people that you know, we know that when they're diagnosed with a condition or somebody tells them that they have a condition, they immediately go where? Online. They go online, exactly. They go to the internet. More and more they start to gather information about their condition. And as the volume of all of this medical and health-related information is increasing, people are sort of bombarded with information. The information that they get sometimes is not accurate. And the problem is that they then make health decisions on the basis of the information that they're pulling off the internet. Okay, and is this detrimental? Yes, it is. So let me give you an example. Recently, the Public Health Agency of Canada conducted a disease-specific survey, and it was administered to patients who either had hypertension or diabetes. I think they've completed those two cohorts. But it was part of the Canada Health Survey, and there was an advisory panel put together, including some people from UHN and myself, who developed a specific questionnaire for hypertension. And what we tried to do was find out from these people, you know, if you have hypertension, what are the barriers and what are the facilitators to your behavior change on the basis of the evidence-based guidelines? So in other words, we asked, you know, do you make lifestyle changes? If you don't, why not? If you do, why not, et cetera, or why do you? And we did this for diet, for physical activity, and for medication. And then as part of that, we asked them, what is your greatest source of information? And guess what it is? It's the internet. Okay, this is problematic because what we also see is that some of the people who are just relying primarily on the internet to make decisions are not necessarily following the guidelines because they're confused by the information that's being provided. And that's not anybody's fault. We're just now living in a technological generation. However, a significant percentage of the information is inaccurate and it's outdated. So, it's not like Google Health says to you, well, here's the most current evidence of the day, because I can go back and research to 1979, and now I'm really confused because I have 20 years of research and I can't distill anything out of anything. And that's why this is really about the fact that we need an evidence-based approach to eHealth implementation. Okay? And we need this because the information that is going out to consumers is not necessarily reproducible. You're a consumer, okay? How do you actually assess whether or not the information about an intervention is reliable? How do you assess whether an intervention works? Should I go have an angioplasty? Should I have a bypass? Should I use this new drug? Think about that because we'll have a little discussion about that. So the key challenge here is to really try to establish how we validate all of the approaches that are being provided to us, but more importantly, how do we then translate that information and disseminate it back to the public in a way that's understandable? Okay, so so the key premise is that we start to actually look at how we're doing this kind of research, and this is a normal sort of journey. And Kevin, talked about a journey. And when we think about the journey of eHealth and all the evidence that we're gathering, there is no real destination, right? It's like being on a diet. You can't say, I'm going to lose 10 pounds, and then you lose 10 pounds and you go back to your previous behavior. Well, then you're going to put on your 10 pounds and then you're going to be depressed at the same time. So at the end of the day, all of this is about a journey, and for people to recognize that eHealth is really a journey. It's dynamic, things are changing, and with the advent of information and communication technology and tools, we realize that things will be changing over time. So why do we actually care about this? Let's take it from the patient perspective. There are different end users in this game. We have patients, we have caregivers, we have clinicians, we have people who are in the home, not just caregivers, but people going in from community care agencies, etc. And think about a patient when they're discharged from hospital. We've done focus groups with many, many patients, and I'm sure some of you have done this also. It's confusing to them. They have a 2-minute interaction, sometimes it's a 10-minute interaction. It really doesn't matter because they don't remember a lot. So they go home and they're confused, and they have pieces of paper that they don't always understand what to do with. Is it our fault? No, it isn't. It's just that's the way that we've been practicing clinically. But now we actually have opportunities to engage the patient, to make them part of the eHealth solution, where we can give them patient portals and advise them and support them. And what do patients care about? What do they tell us about what their interests are? They want to know whether or not the doctor has the solution to their problem. This is very important because when you talk to patients, when they go in to see a clinician for a consultation, they go in armed with information from the internet, right? So, am I making funny noises? Or okay. 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 So, they go in because they don't really trust that the physician knows them or whoever they're seeing knows them. And that doesn't mean that the physician doesn't know them, it's just that the patient has doubts. And they're given so much information that they begin to believe that they know as much as the person they're going to see. Okay, that's really where we're at right now. So they want to have some confidence that the physician knows the solution to their problem. Keep that in mind because I'm going to show you some web-based tools that we're currently using. Where can I get more information about my condition? Thank you, pharmacist, or thank you, doctor, thank you, nurse practitioner, for this information you've given me, but I'd really like to do a little bit more research. What do we tell our patients? What do we tell our patients when they ask for more information? Right? We don't have a great answer. So is it time that we start thinking about, trusted URLs, trusted information that we can share with our patients? What is the best therapy for me? I know what everybody else gets, but I'm an individual. How are you going to personalize what you're doing for me, and how do I know that it's the right choice for me? These are questions that patients are asking. Are there alternatives? You know what, I really don't like to use drugs. I would much rather use a natural product that is medicinal based. Well, is there something available? How do we answer those questions? What are the side effects? The greatest reason why people discontinue medication, other than the fact that they forget to use their medication, are side effects. And do you know how many times we change medications because patients have side effects and they stop using it and they don't actually tell us they've stopped using it? So we just keep changing and adding and subtracting without really knowing what's going on because our systems are not linked. Who's got that single record? Nobody, right? Think about it. I go to the hospital, I have a prescription, 22% of the people never even go to the pharmacy to have that prescription filled, but you, the doctor, don't have a clue because you have no link to the community pharmacy. The pharmacist has information about the prescription that's getting filled, but they have no information about what the diagnosis was necessarily or whether or not a drug was titrated up or down. Do you see the disconnect here? And yet we talk about eHealth. And what are the patient's experiences? They want to know about, well, how many patients have you treated? There's some excellent work being done in different parts of the world, but one of my colleagues who was from McMaster, Victor Montori, has done a lot of work with decision aids, where you try to educate patients on the basis of other patients' experiences. And how convenient is this service? If I'm going to be expected to embrace eHealth as a patient, will I be able to use this? Will I understand how to do it, etc.? And as I said, feel free to ask at any time if something doesn't make sense. You just need to stay awake, and the only way to do that is to ask a question that you won't insult me. Okay, so what do we talk about when we're talking about evidence-based medicine? Essentially, we're looking at applying the best available evidence. If you think about the traditional way of thinking about evidence-based medicine by Sackett and Guyot, you have levels that are based on whether, so essentially they go from a level 1 to a level 5. Level 1 essentially are systematic reviews, which are done on the basis of many, many randomized controlled trials. And then level 5 is really expert opinion. So you have this whole range of evidence. But in eHealth, do we follow that paradigm? I don't think we do, because what I see is people are using a lot of different, what they call solutions for eHealth interventions, but they haven't really followed the paradigm of the evidence-based matrix. Okay? And you could debate that with me and feel free to do that afterwards, but I'm suggesting that perhaps we actually start to look at that, because the fact is that we have a number of problems. And what are those problems? Some of the problems are that some of the eHealth research has been haphazard. Is that intentional? Not really, but sometimes it is, because all you have to do is go on to Bloomberg and see, just in the medication adherence world alone, last year pharmaceutical companies spent $75 million on solutions. And those are just companies that tell you how much they've spent. And I could be a solution provider, because I could say I've got a solution, and you now are going to buy my solution, but how do you know that my solution works? How do we actually assess the value of this intervention? And it's not just the economics, it's how do I know that I'm going to do more good than harm? And we don't consider necessarily the harm from the intervention. So this is a problem, because people are developing tools that are not well documented. And I'm not suggesting everybody's like that, so I don't want to give that impression. But the tools that are being developed sometimes are by companies who don't necessarily have the foundational training in evidence-based medicine. They're being done because there's a need, there's a thirst for solutions. And whenever there's a thirst for something, everybody has to provide a solution, and then I have to buy this solution because I now feel that there's a need, and I'm doing this because everybody else is doing it. You think about quality of life as an outcome, and I'll just use as an example. About 10 years ago, people decided that quality of life was important. The FDA decided that quality of life of a patient who was getting a drug was important. So guess what? Everybody started doing quality of life in every study that they ever did. And what do we do with that data? I don't know. So, I mean, that's where we are right now. We're doing stuff, but do we really know why we're doing it? What are the limitations from a physician perspective? I've already mentioned they sometimes have to provide patient care without critical data. Think about this. I come into the hospital, I'm admitted to hospital, there's an electronic medical record for me. However, a physician also has me on a study. There's no link in that electronic medical record that I'm on a study. that study drug may be causing side effects. Well, who knows? I have no idea. And guess what? Me as a patient, I have no record of anything because I don't even have access to my own record. Okay? And that speaks to Kevin's point about making sure that the patient actually has some access to their information and they're able to share it with people. And this is an important point that we have to start to think about. The level of evidence in health-oriented internet websites cannot be assessed and often does not exist. And I'm not going to pick on any one site, but I'll use the example of WebMD. WebMD has excellent information, but it's not about me. It's about general information that's available. So if I sign on and say I have osteoarthritis, it will give me a whole constellation of things that I may or may not do, but I don't know if that's actually for me or if it's based on the evidence or what it's based on. And you know, that's one of the best sites that's currently out there, but once again, it's not personalized. And how do we begin to take information that's available and personalize it? The other thing with the web, we've got to remember that anyone is able to publish and explore information. So I can publish anything I want, I can put it on the web, and guess what? If I pay Google Ads enough money, my website will come up first. And you're going to think that I'm a really, really good website because as soon as you put in, I think, or health informatics, it'll come up and you'll think, boy, this is really good. You know, it came up first, it must be solid. No, it isn't. It means that I paid money to Google to make sure that my site came up first. Do you see my point? So there's a way to manipulate the web, and patients don't always know that. Lay people don't know that. Most of us don't know that. Okay, so we need to have mechanisms to provide trusted sites. And why? Because we want to make sure that the information is robust, that it's replicable, and it's representative. And right now, we have no way to do that. Okay. So how do we actually incorporate evidence-based medicine into eHealth? Well, the first area that I wanted to talk about was appropriate context. So the context plays a significant role in shaping the evidence, and we should make sure that the information that we're providing is available to people across multiple settings. The context means that it has to be relevant to me, the end user. Have you ever gone on to Google something or gone into a website and typed in something and it gives you something totally different?
Do you mean?
What's that?
We'll ask you if you meant that.
Yes, did you really mean? And then you go, yeah, probably I meant that, or I'm not sure if I meant, but that looks like an interesting thing. I think I'll read that first before I go read what I'm doing. Exactly, right? So what is the context? And how do we begin to develop filters so that patients understand how to use the system? The second is a supportive environment with appropriate feedback. So when we think about eHealth, most of the time we want to use these types of systems. It's actually two reasons we like to use these systems. One is really as a patient health record. I'm a patient. Let me use the example of medical tourism. I just finished doing a 2-week tour with our consulate in India. And medical tourism is a big business in many countries, and we have many Canadians who go overseas and vice versa who come here. Doesn't matter which country, Costa Rica, the US, it doesn't matter. So I'm going now to a foreign destination. You're my treating doctor. What do you know about me other than what I've told you? I now come back and I see my regular physician, and what does he or she know about me? Nothing other than what I brought in my file. And most good hospitals will give you a copy of your x-ray. But if I actually had a web-based system that allowed this portal for information to be collected, and I'm not suggesting, you know, that this information comes that I have my entire electronic medical record that I'm running around the world, because we know that that's not optimal based on what we've seen from, you know, the Google Health and Microsoft Vault, that there's certainly some concerns. But in terms of treating and portability and those types of things, we've got to look at ways that are supportive for people who are embarking on different initiatives, whether they're going into different countries, etc. So right now we have no way to exchange information between countries. An excellent model to look at how this works is actually the US and some of the very good health maintenance organizations like Kaiser Permanente. If you're a Kaiser patient, you actually have access to your entire record anywhere in the world. I fall off a horse somewhere and I break a leg, doesn't matter, because I can actually have the physician who's treating me in any country go on to my record with my permission, with my password, and access and see what drugs I'm on, etc. We can't do that today, at least not here, and certainly not in most countries around the world. And I'm giving you the example of one of the best HMOs in the United States. Most of the time that doesn't happen. But why not? And I'm not suggesting we have an answer. We know that it's possible. Okay. What about assessing the effectiveness of the evidence-based interventions? So I have an intervention. I'm going to put you on my web portal. I'm going to help you manage your diabetes. And how do I know whether or not you're managing your diabetes? How do I know if I'm changing your behavior? Well, I don't know. I think I'm a good researcher, so I come up with my methods and I implement them, and then is it reproducible? Well, I don't know. I just know I made a difference. Was it the web portal? Was it my intervention? Was it that I had a great personality? I don't know, because it's not reproducible. And this is the problem that we're having with a lot of these interventions. They're not reproducible. So I'm going to talk to you about some of the projects that we've done, just to try to put it into perspective. So we've done a number of studies. We actually build web portals in our lab now. This was a study, however, that we did that was funded by the Health Technology Exchange with a company out of Waterloo that actually isn't in existence anymore. However, it allowed us to begin to track patients after they left the hospital. And we did this in diabetes, and we did it in heart failure. That was a heart and stroke funded study, and we did it in prostate cancer. And the idea was, let's begin to understand whether or not people, A, want to use these systems. I mean, we may like web-based systems, but maybe older people with a median age of 74 don't want anything to do with this. And are they using it? Is it making a difference? And if it's not making a difference, let's sit down with them and understand how we can improve our systems. And so the lesson here that we found was that, and that's why we did pilot studies, you can't just take a solution and implement it. People think about, the fact that, boy, eHealth is great because it's web-based and we can implement it and we can disseminate it, and hooray, because people don't have to make long trips to come in and see the doctor, and we can interact with everybody, using telemedicine and web-based tools. Wake up. People aren't doing it. Okay? And we're making an assumption about the cost-benefit analysis and our ability to disseminate these types of tools. Think about a heart failure patient where your median age really is somewhere between 72 and 74. Okay, these are not people who always have computers, so we're making assumptions about being able to implement it. Now, when we did our pilot study, I'll tell you that the diabetes population were younger. They were very much engaged, and I'll show you some of the slides from that project. But at the end of the day, because we were able to educate older patients about the importance of being able to track their own weights and put it online, and we're able to give them information and education that they were able to pull out at any time and share with their family members, we actually had excellent uptake in that project. But I also want you to think about the investment in time that we undertook to implement this project. Okay, so I couldn't just say to somebody, okay, it was really good to see you, you've got heart failure, here are your medications, I've got some booklets for you, they're from Heart and Stroke, etc. And by the way, sign on to this web portal because it's got tons of information. Nobody signed on if you do that. And we did try that. We wanted to see whether or not, without active engagement, whether people actually understood what we were talking about. In the second model, we sat down and we said, okay, you know what, you've got heart failure, you're on multiple medications, we're going to input the initial information for you, and this is how you use the system. And we actually spent half an hour with them, educating them about the use of the system. We set up webinars for them and a 1-800 line that they could call at any time. And we encouraged their family members to call us. In that system, we have had over 90% participation. Okay. So when we start to think about the implementation of evidence-based, and the evidence here is really the education and the behavioral change and the self-management strategies we're giving them, we can't use electronic tools if nobody knows how to use them, right? It's no different than giving somebody with health literacy problems a booklet and saying, this has everything you need to know. Just read it. another example in the heart failure, which really, I didn't understand until I started talking to patients. We tell patients, what they should eat, and the fact that green leafy vegetables are excellent and low salt, this and that. And this older person said to me, "Excuse me, madam, but do you know that I'm on a fixed income?" And I said, "Okay. And I can't afford green leafy vegetables. And by the way, I buy soup, which generally has a lot of salt in it. I won't name it because you're taping this, right? But I think you know that most condensed soups have a lot of salt in them. And that's what they eat. If it's on sale, I buy it, I eat it. I don't even know what you're talking about, green leafy vegetables." Think about it. So we've got all this evidence about what we should be teaching, and then we have a population that isn't able to receive that based on their own constraints. And these are just different screenshots. We've done a lot of work. We've just finished a big project in prostate cancer that allowed us to collect health-related quality of life information for patients for a new drug that is just being launched because there was no information about any cost utilities or quality of life in that patient cohort. So there's a lot we can do with this. So here we use this in asthma. We use this in diabetes, and this was actually a lot of fun because patients could actually upload from their glucometer directly onto the PC, and they were able to see in simple terms, and this is where visualization is key. I know that red is bad because when I run a red light, I'm always looking to make sure there's no policemen behind me. I mean, I didn't do that on my way here, just so you know, even though there were people honking at me at bay and blower incessantly to turn. Green, fine. I'm in the safe zone. Blue, time to take another look. You're dipping. There's a problem. Simple. But when we educate our patients, do we show this to them? We show them numbers, right? Your blood glucose should be between 5 and 7. If you're at 10, you're in trouble. If you're this, you're that. Yeah, okay. Now, how am I going to remember all this? I can barely keep my grocery list straight when I go shopping. So, being able to use, there's a lot of hope here. So I don't want you to think that, this is all hopeless. It isn't. Because now we can engage them, because I know that red is bad. And I know that I have to call my doctor or my nurse practitioner or somebody and tell them that something's wrong. Or I realize I can't have dessert and wine for dinner. I can only have one. So, there's a message in all of this. Okay, and so you can use these tools to provide feedback to patients, and that's really the exciting part where we've done this, where we set up a web portal for patients so that they could communicate with one another. And it was moderated because we didn't want anybody, to try to date one another or do any of that kind of stuff, but to ask legitimate questions, to share tips with one another. Like, I find that if I have, this many carbs at night, I run into problems. Or if I'm a heart failure patient, I find this. And it was really interesting because they shared a lot of valuable information. Think about that. Think about the strength of social media. In every major project that is being done globally right now, whether it's by the CDC, the WHO, a lot of the European framework projects right now all include a component of social media. And why? For two reasons. It allows patients to communicate in a moderated environment. It allows you to disseminate information to them about new medications, new studies, new information. But also, as important as that, it allows healthcare providers to communicate, right? So now you have a network of physicians. You have a network of nurse practitioners. You have people who can share information with one another so that they're not feeling like they can't make a decision. There have been some excellent studies that have come out of Spain and the UK that have actually been able to implement care maps so that when a patient leaves the hospital, the nurse can log on in their home and say, okay, this is what happened, and this is my role. This is what I have to do with this patient. I can now log it, because right now we have no continuous record for our patients, right? The hospital record is here, the pharmacy record is there, and everything else is somewhere, and we don't know where it is, other than on little bits of paper. So think about, where we can go with eHealth in the future. So I've talked a lot about, the context, the effectiveness, why we actually need to start to implement some ways to address this whole issue of the assessment of eHealth tools. I'm going to show you a few other prototypes. My disclosure here is that most of my programmers are actually colorblind. So we, and I don't say that as a joke, but everything is gray and black. So when they go live, we actually have different colors, but when the programming is done, they can't tell. So we actually built this for patients and for physicians. It's a melanoma registry. It's the first registry that was implemented in London. We have now just received funding to develop a national melanoma registry, which we're really thrilled about. It'll be in 11 sites. So who cares? Well, who cares is that if you think about, physicians who are treating any particular subspecialty, electronic health records are not built for specialists. They are built for the general population. And we realize that because physicians were saying to us, well, when patients go home or when they finish their chemotherapy treatment, unless they're in a clinical trial, we're not able to capture all this information that's really important. And we built this system two ways. One, you'll see here, oh, I do have a pointer, I forgot about that. When a patient goes in to see the doctor, the cancer specialist can actually take their mouse and click on where the tumor is. And the size of the tumor goes up or down based on the visit. So when the patient initially comes in, they have a tumor, they mark it. That's fine, except that when the patient is actually waiting in the waiting room, they also get something on a tablet like that. So when they're waiting in the waiting room, they have a tablet, and they can mark for the physician where they have pain in their body, or they can complete quality of life information, or they can tell the doctor about how they don't like a particular medication because it keeps them up all night. By the time the patient goes in, because they've been waiting now for an hour and a half in the waiting room, by the time they go in, it's a dynamic system. It's already integrated. Everything that they collected in that waiting room is now on the physician's portal. So when they come in, think about if you've ever been a patient, you'll understand this, because 10 people ask you the same question over and over and over again, because that's the way every healthcare system is. And by the time you get to the last guy, who's probably the most important person who's going to be treating you, you're exhausted. And you get cranky and you don't tell them everything because you're tired. Okay, but now you don't have to, continue to repeat yourself. It's now a relationship between the physician and the patient or the nurse practitioner, any healthcare provider. So all of this is done dynamically, and there is a patient portal. So when the patient goes home, they can input information. Yes? Can you upload pictures? Yes, you can upload pictures. Yeah, we're just doing a big project in Ontario for OICR, Ontario Institute of Cancer Research, where images are actually in our system uploaded right off the PACS machine, as are JPEGs. So if I take a picture of a melanoma or a wound, it just gets uploaded.
So it would be interesting if you can tag it, like tag each one of those with the picture of that.
Right, so we can do that. I can't show you that because I'm not live, but we've just started doing that now, and it's a great idea.
How have you integrated this with your patient records? London has Cerner.
Yes.
And one of the things we always hit is, often research is seen separate from the clinical environment. So how are you bridging that?
Okay. So that's a really good question. Yes, London is Cerner. And what we did for every research project, because we have REB approval, we were able to negotiate. We have to get into queue, but we get data from Cerner put into our system. Okay? It's not a fully integrated push and pull system, which we're actually working on now at a high level with our VP in charge of the IT and other people, our medical informatics officer, because they're beginning to see value in having an integrated record. So for research, because this is also used for clinical management, okay, because as you know, the Cerner system does not have every specialist portal or prototype set up on it. So there is. There is. So for clinical, all of the information is not anonymized because it's being used to treat the patient. What happens then is for research, we actually anonymize it. We push it outside of the firewall into what we call a demilitarized zone, which is basically a cube where there's nobody standing with machine guns, basically. No, I'm just joking. That's not what a demilitarized zone is. And the data goes in there. It's anonymized. It's been encrypted, and it's transferred so that a researcher now, with appropriate approval, can do the research that they need to do. Okay? So we are working very, very closely with some of the providers. And right now, we're only at the pull we can't push. But what we can push are synoptic notes. So physicians in our system, when they're using it for clinical management, do not have to dictate a note. They just click on the variables that they would normally put in a note. It creates a sentence structure for them, so it's uniform, and they have a space where they can actually write, something nice or whatever they want to, a narrative. Everything else, they pick from the quantitative data, which means that we can in the future mine that data and look at it carefully. It gets PDF'd and uploaded right into the Cerner system. And the patient also has a portal at home then. Any of the tumor staging, etc., is all done automatically in all of these. Okay. And what we started doing more recently is the use of phones. So one of my colleagues, David Spence, is a neurologist. He's based out of London. He's also the co-editor of Stroke. He's done a lot of work. Do you know Spence? Okay.
I don't think it's the same guy.
Okay. So David is a clinical pharmacologist and a neurologist, and he heads up one of the largest arthrosclerotic clinics in the world. He has 10-year longitudinal data. And as part of that, what he has done has developed some tools where you can scan the carotid and you can show, he can see the plaque and measure the plaque. And he came to our lab a couple of years ago and said, wouldn't it be really cool if you put this in an iPad for me? He was trying ways to get an iPad out of me, but regardless, this would be really nice for a patient to see. So when we're explaining it to them, we scan the carotid, we show it to them on some kind of a device, whether it's an Apple device or an Android device. And so we actually built that for them. And so the physician can actually enter data right on the phone, and the phone's got a tiny picture, but we're doing it now on an iPad. And we've done the same thing in the NICU, where everything is entirely wireless on an iPad, including all of the querying tools. And that's just gone live recently with Dr. Rokma. So why am I telling you this? I'm telling you this because the patient is a key part of this. Okay, eHealth is not just pushing information out to the patient, it's engaging them. We want to make sure that they're staying out of hospital, but we need to give them tools, and we need to make sure that the tools that we're giving them are actually evidence-based. So what am I talking about? So let me give you an example. Everything we do in the knowledge translation trajectory, so in this particular project, what we've now done is we've just submitted to CIHR a proposal, so who knows if it'll be funded or not. And it's about the visualization of my own plaque and whether or not it encourages me to change my lifestyle. So it's visualization as a tool with other kinds of tools around behavior change, including motivational interviewing and other tools to help patients change their behavior. Because, if I go to the gym every single day for 10 weeks and I don't lose a pound because I'm putting on muscle, but somehow that doesn't compute in my brain, I'm just going to become depressed and, give up because I want to see that instant gratification. But I also know that I'm at risk because I have high cholesterol. But how do I know whether or not my cholesterol is going down? Yes, I can look at my LDL, and that means that I have to go in and have my blood work done. But I would also, if I can see my plaque and I can see that my plaque is going down over time, because now it's not just my high blood pressure, it's the fact that untreated or uncontrolled blood pressure is going to lead to a stroke. Is that going to make a difference in my behavior? So we do test everything we do, and I'm going to bring you full circle to the fact that, we're not just implementing solutions. We're not saying, boy, this is really cool, we should use it in everybody. No, we can't. Because do we know whether it works? Do we know that whether or not it'll cause more harm than good, right? Am I going to be so scared that I've seen this plaque that all I'm going to do is have nightmares every night about plaque in my artery because I didn't know about it before, and it was probably better that I didn't know about it? Okay, so that's where we have to actually undertake the same rigor that we did in clinical trials. Okay, so where are we going? What are the new research directions, or what should we be doing? And this is only, based on what I think. We need to make sure that we're actually understanding whether or not an intervention is effective. Okay, so what are the methodologies? What are the designs we should be doing? Can we just launch into randomized trials? No. Can we use cohort data? Yes. Can we start to, in the world of randomized trials, people don't like to do quasi-experimental research. But perhaps in this area, we need to look at different ways to research these populations. We're giving them different tools, whether it's phones or the internet, So let's look at what those designs should be. And I'm not saying I have the answers, because I was also trained traditionally, but now we need to look at new ways to engage people and to test these methodologies. You asked the question about embedding in other eHealth systems. That has to be done. But can I do it? No, because all I can do is put pressure on one provider and then put pressure on people above me and below me and beside me. But I think as a collective, if we start to think about, we're not a threat to providers of electronic medical records. In fact, we're beginning to enhance their products, and what we're doing is better for the patient, so why can't we have interoperable systems? Is that the end of the world? I don't think so, right? So we're talking about collaboration, not competition, and we need to think outside the box about that. And we have diverse users. We have people who don't speak English or French or Spanish. What are we doing for them? So we've just started a little bit of pilot work now where we're building animation for these patients to educate them, and we're doing it to explain to them their disease, their lifestyle, and their medication, and we're doing it in any language because the way we've written the code. So we're beginning to understand that a booklet is great, but it's in maybe 2 languages, but I don't understand either of those languages. And by the way, my regular diet is not sandwiches anyway. I may eat lentils. And most of the dietary stuff you're giving me is really all about a diet that I don't even follow, so I don't know what you're talking about. So when you think about what you're doing in global eHealth, how are we beginning to address the diversity of our populations, both from an ethnic perspective, from a health literacy perspective, from an economic perspective? People can't afford to do everything that we should be doing. I can't have a gym membership if I can't afford to eat. So what is it I'm going to be doing to improve my health status? And then, how do we start to look at some of the development strategies and dynamic interaction, which I think is going to become the next area. If you look at what's happening with eHealth and some of the new tools that are being used with videos on mobile phones, they're being used in many emerging economies. We're not even doing that here. I mean, I don't know why, but so we need to learn from people around the world. It's not like we have all the answers. And I know at the end of the day, we're all hoping that eHealth will allow us to be generalizable to the whole population. But we don't even understand what we're doing right now in this domain. That before we try to disseminate the solution, we need to be more cognizant of what it is we're doing and whether or not we can reproduce it and whether we're doing more good than harm. And I know I've repeated that more than once, but I stress it because I see so many things around the world that have not been properly tested, but they're a great commercial success. Why? And there's nothing wrong with commercial success, but we just don't know what the end game is. Okay. So, and in summary, what I want to just reiterate is that we want to turn the information that we have into knowledge. Okay? We want to be able to take information in a way that's understandable to our patients, to our caregivers. There's some interesting work being done right now out of McMaster where they're looking at engaging the caregiver as part of these eHealth strategies. So let's sort of move out of the paradigm of just thinking of an individual and think about the community, and that community could be the caregiver, the patient, family members who are not attached to them at home but may live at a distance, who could also provide great support. There's an interesting company out of France called Sensilia, and what they've been doing is using social networking for older people. And they came to Canada a couple of times to show us what they've been doing. It's very interesting, using touchpad technology and webcams so that you've got your family members who can actually call you and say, hey, Grandma, how are you doing? Did you remember to take your medication? And they all have passwords. They're all vetted. But it's also, it's a very nice environment for an older person. And so they've now started using that in older care homes and those types of environments. And yet, because families now are not centralized units that live in the same place, they're all over the world, the family can still provide that support to a family member using this type of technology. So I think there's great value there and some very interesting work. And these are just some more screenshots of some of the work that we're doing in this is a CIHR funded study where we're actually looking at, we load the image of the prostate cancer, and it's shown to the patient. But in addition to that, it allows all of the data for that patient to be in a complete record, including what's in the health record in this particular study. And I've put a little tab here. It's called Analytics. And one of the other messages from eHealth is that in this country, we spend so much money on data collection. If you add up how much money we've spent, it's just unbelievable. But we haven't done a heck of a job about mining our data, understanding what to do with our data. How do we use, I mean, you talk about an electronic medical record. Who goes into a Cerner or a McKesson? Who mines the data? Who looks at it? I mean, we have valuable information that we're not currently using or being able to use to actually help patients at a wider level. And I know, you know, it's not a simple solution. There are lots of issues at hand. So I think that's my last slide. And in summary then, evidence-based strategies, they need to be implemented. We need a more rigorous evaluation of what we're doing and the effectiveness of what we're doing in an eHealth system. We can't be just excited about the technology, baby steps, right? We need to follow the same things that we do with clinical trials and new drugs. We don't go from phase 0 to phase 4. We do 1, 2, and 3 along the way. It's no different here. We have to do pilot studies. We have to sit down with our end users, whether it's a physician, whether it's a patient, do focus groups. Do you like what we're doing? Does it make sense? Does it not make sense? Tell us. Let's refine this so that we move to the next level. And then we do the randomized trials. And then we have something that we can actually provide as a solution. And this is very important. Training and support. Okay? I use the analogy that, you know, I could have the fastest car, but if I don't know how to drive it, what good is it? And that's what the internet is, right? It's a fast car. If I don't know how to use my web portal, if I don't know how to look after myself, if I don't even understand what red, green, and blue means, who cares? It has no value. So we have to make sure that we're educating everybody along that journey so they understand the value, all the way from the physician to the patient and their caregivers. Privacy, very important, okay? Password protection, encryption, making sure that we're using appropriate servers, that we're using zones that have been vetted and approved by eHealth Ontario, that if we're beginning to use Bluetooth devices, you know, understanding the legislation about the utilization. If we're using this as a communication tool, and I think Wendy Graham will talk about this too, where patients and physicians can talk, but you need to make sure that you're using secure methods to do that, and to understand, you know, the downside also. We do, however, need to bring innovation. Okay, about 7 years ago, or maybe less, I was at a talk in California, and it was actually Newt Gingrich talking. He was the keynote speaker, and I was the end-of-day speaker. I don't know how that happens all the time, but anyway, he was talking about the fact that they in the U.S. cannot afford to look after people who are getting sick because they have 10-year-olds and 9-year-olds with diabetes, and this is like more than 5 years ago. And unless we begin to support patients with self-management strategies, we're going to be in big trouble. I have just seen the reports, as I'm sure many of you have seen, about the cost of health care in this country. This weekend I was privileged to attend a conference where they had presidents from 3 universities in Canada, but they also had Lucien Bouchard giving one of the keynote speeches, and it was a conference on education. And the reason that we don't have money for education, to paraphrase, is that we're spending so much money on health care that there isn't much left for education. And can we change that overnight? No, but I suggest that some of the strategies that do include eHealth and information and communication technologies could be key. We just need to make sure that we're not misappropriating them and that we're applying things in a rigorous way and that we start to set a standard. And this is what we did in adherence, because people were doing adherence research everywhere. I didn't know whether it was adherence, compliance, persistence. I don't know what they did, how they did it. We said, you know what, the time has come that we need to get people to follow rigorous methodology. It's not that they didn't want to, it's just nobody had ever said, you've got to do it this way so that we understand, so that we can reproduce your great idea. Because if I can't reproduce it, what good is it? And that's how we started to build that community of research.